George, it's Tuesday afternoon. It's a beautiful afternoon in Virginia. And we have a very, very special guest, Dr. Sabrina Braham, will be joining us today. And we're going to be talking about innovation in pediatric medicine.
Today, we're going to do it a little differently. Usually, we're the guys doing the questions. Sabrina is going to be questioning us. Could you imagine? So take it away.
Great. So welcome, Sabrina, and you'll be our first guest host. Take it away.
Amazing. So I should probably start with how I found you guys, right? And maybe a little bit about why I reached out. When I left my practice, I was in community practice for 12 years. And when I left my practice to think about how we could reimagine how we deliver child health. So I've admired your work, both of you. Your podcast is probably some of the best programming for pediatricians that I've come across. And I'm curious, how did the two of you start the Pediatric?
Well, thank you. The Pediatric Lounge was a dare and a joke. So our good friend, Dr. J. Michael Connors, a pediatric emergency physician, kept complaining about how we are all pixie dust, cockroaches, and we're all going to be working in Walmart as greeters if we don't change our ways. And I said, well, let's quit complaining. Let's do something about it. And Mick said, well, what do you suggest? I said, well, we lost our voices. Who has a voice in healthcare today? The legislators are mostly lawyers and don't have a clue as to what they're doing. And the hospital administrators are probably a little less clueless than your legislator. And the doctors don't get together. We don't get out of our offices. We don't break bread together. We don't sit in the doctor's lounge together. And that's why they're winning the battle and no one hears our voice.
Yeah, and I was always upset. I would go to conferences and I'd listen in on the different practice management conferences, and everybody's talking about doom and gloom stuff. And I went up to a lot of the people that organize the conferences and I said, you guys have a captive audience. Instead of doing the doom and gloom story, why don't you share good stories? And nobody ever did. Then I met Herb and we decided, let's go to a place where the doctors used to go to talk about things, and let's elevate great physicians and great stories. Hence, the Pediatric Lounge was born, a place to elevate great physicians.
Love that. I love the piece about it that's also really important is that you guys, the content of your interviews really gives practicing pediatricians actionable information about how they can improve their practices and improve their work-life balance. How long have you been doing the podcast?
Almost a year now.
If you had to sort of nutshell what you've learned, high level, what do you think are the take-home points?
I learned that there's a lot of great physicians out there that are the best kept secret in the world, and nobody knows about them because they're doing a great job every single day. And all you hear about is the bad stories, and I'm tired of the stories.
What about you, Herb?
I think that there's some phenomenal old school physicians out there, people that go home and they worry about their patients and they go and read at night when they get home. They call their friends. They ask their friends around. I've always thought of physicians as firefighters or police officers. We're brotherhood. We go home and we worry about our patients. That's a good physician. There is no clock in medicine. The clock is always right. So it might be 5 o'clock, but I'm still worrying about that kid that I'm sure about their diagnosis and couldn't get him to the specialist. And we hear that story over and over, and the empathy and the compassion and the joy that pediatricians get from being part of their community and the relationships that they built. I thought, honestly, that had all been lost because of corporate.
So I could not agree with you more. I think what I experienced coming out of my practice is that you were exactly right on that there are incredible pediatricians out there. I happen to be of the opinion, and I know that you probably share this, that pediatricians are among the best and most conscientious physicians around, and we really truly own our patients. But what I experienced is that it's increasingly difficult in our system to care for patients. The quote that I always use is that it felt like I would get out of bed and want to give 400% to my patients, and they would still leave the office like feeling like they'd only gotten 10% of that effort.
Why is that?
Well, so that's the question I have for you guys. What I've spent the last couple of years doing is trying to understand what that friction is. What is the friction in the system that makes it feel like people, I mean, in life, if you look at any industry, you won't find people who are more dedicated to their crafts than pediatricians, I mean, really mission-driven people. And so how is it that if you look at the metrics for pediatric outcomes, we're not doing great? And so the conclusion I came to is that it's this friction in the system. So then what's the friction? I have some thoughts, but I'm curious what you guys think.
Oh, I want to hear your thoughts. I'll tell you the answer.
Well,
I'll
yeah,
tell you my thoughts.
No,
Okay.
let her tell us her thoughts here.
All right.
I came up with this concept of the pediatric paradox. And basically, it describes this idea that we all say we care about kids, but our system's not set up to care for them. And more specifically, what that means is the goals of pediatrics, the goals of child health, the goals of families are long term, right? Thriving, flourishing, functioning well in school, functioning well in the world. These are not outcomes that are incentivized by the fee-for-service system that we all exist in, right? And so the extent that you are operating in that environment, it's going to be always really hard to do the quality of work that you want to do, given the constraints, right? Because you need to have, even before COVID, we needed to have visits instead of making it more convenient for families doing a video or a phone call when we know that would be just as good, for instance, for counseling. So that's the first thing, is the sort of misalignment in how we pay for healthcare. I think part of that is because pediatrics is really two things. It's public health and it's medicine, right? And so all the public health pieces that in most other countries are paid for by the government, pediatricians are doing, and most people don't realize we're doing that, right? It's a dietary counseling, it's developmental counseling, it's sort of all of the preventive steps that we do. That's how I think about it. And then you sort of look a little bit more closely at our payer system because of the fact that we have employer-based insurance and we have this churn where patients or families are changing insurance every 2 to 3 years. There's even less incentive for any one payer to care about long-term outcomes. And so for that reason, we have another paradox, which is that we spend the least during a period of time when we are likely to have the longest and most significant impact in population health. So I guess my answer to that question is really that it's just a series of misalignments, and that's what results in this friction.
I could see that.
You're not buying it.
Halfway. I'm buying half of it. I'll tell you, that's the academic answer. All right. I'll tell you the practical answer. Everybody blames it on fee-for-service and all that kind of stuff. They don't even know why they blame it on fee-for-service. Why do you blame it on fee-for-service?
Are you asking me?
Yeah.
Well, no, let me hear your thoughts, George, and then I'll give you my thoughts.
Yes, they should pay for the developmental screening. A lot of them do. But if the Medicaids and the Medicares, they don't put a value to it, then the insurance carriers won't pay for it. Preventative care, well care. There's no Medicare value for a checkup on a kid. So the insurance carriers can't plug in a number. So that's pretty pathetic. They should give it a value, but they don't, because most of the contracts.
How do you value that? That's the problem, is we don't know how to value these long-term outcomes.
Well, yeah. The obesity and, all those things, the dietary stuff, they should be paid. Yes, they should be paid. Should we be spending an hour and a half for every patient that has obesity? No, but you should set up a work plan, a workflow to be able to manage these kids, because we've seen it in my own practice. We have one doctor that does a lot of the obesity management. So he does good quality. Okay. Great quality, superior quality, I would call it. He generates less money than me. We went to school together. He used to generate the same amount of money as me. But we, as an organization, decided that the quality is important. So he will do that. He will see less patients for a longer period of time using the same codes that I use, maybe a higher level. And in the grand scheme of things, it'll be okay. And we'll be doing good for society. And, it'll be fun because there's not enough ear infections for everybody to check, to take care of. But not everybody looks at it like that. I could look at it from the point of view, well, we're partners in the organization. I generate more money than you. Why are we splitting everything down the middle?
A lot of people do look at it, and everyone has their own they're coming to the table with different needs
Yeah.
and incentives, right? So if that person needed to be more productive and needed to take home
Right.
more pay, then they
Right.
wouldn't be able to practice that way.
Yeah. I always believe in do good quality and the money would follow. If you follow the money, you'll never do good quality.
Yeah.
Makes a lot of sense.
Yeah.
know? So he's
So
doing good quality. We're doing the obesity stuff. He's having good outcomes in his obesity program. And then you expand that into other contracts, value-based contracts, performance contracts, increasing your negotiation power by saying to the insurance carrier, I need a better Medicare reimbursement rate because we have Dr. X that's doing the obesity management. He's had good outcomes and look what's happening. So we can't work on just 100% of Medicare or 90% of Medicare. Unfortunately, the Medicaid, they don't do that. And a lot of the children have Medicaid.
right.
Yeah.
So
Yeah.
What is your
so
thought, Herb?
well, I think that we don't have a problem with quality healthcare in America, and we don't really have a problem with access to care, except if you're in very rural or very urban sites where it's very dangerous to be. The
I
problem,
agree with that, but we could talk about that later.
but the problem is the way we finance healthcare. So Medicaid is a joke in most states, and it undervalues the care that pediatricians and internists and family doctors give to patients with Medicaid. But they're happy to say, you have insurance now. No, well, you have a government aid program that pays so little that in Virginia, 50% of pediatricians can't afford to see Medicaid patients. So you can go to the emergency room and, maybe a federally qualified clinic. The second problem we have is this crazy idea that came about in the Second World War. That they couldn't raise salaries. So instead, they added health insurance to the employees, and it is a non taxable event. So the customer, person using, has no idea how much that company's paying for their health insurance. So you take a car guy in Michigan making 60 grand a year, and GM's paying $30,000 a year to insure their family. And it's zero co-pays, no, prior auth. They can go wherever they want. And he or she has no clue what that's costing. And they never pay taxes on it. They're just like, that's what my union, I negotiated. That creates the same setup that we have with the failing public school systems. So when you sit down to negotiate, it is the health insurance plans will benefit every time that the premiums go up because they get 15% of all the premiums they collect. And on the other side of the table are the nurses unions of America and the health systems of America. And neither one has skin on the game.
Mm.
So what happens is I'm a big health system, Stanford, and I say for an MRI, I'm going to charge 2,000 to 500, Blue Cross Blue Shield. And Blue Cross Blue Shield says, well, no. And I go, oh, who else is going to do that MRI in this regional area? There's no one else to do it. You think the employees at Apple's United Healthcare, but you think the employees at, blah, 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 are going to be happy because they can't get their MRI at Stanford? And they're like, no, okay, we'll pay that. Then they go back to Apple and go, well, premiums went up by 15% because that's what the cost of insurance is. So, like the school systems, they don't have any skin in the game. They don't have any reason to think about quality. They don't have any reason to think about cost because I send my kid to the school. No one charges me anything. So I get what I get, right?
Mhm.
And that's the same thing with the person that's insured through their employer. They never see what it costs to be insured. And so I have no co-pays. I'm going to go to the doctor 10 times and the ER twice. What do I care? It's a benefit of my union provides for me. And then the negotiations totally out of kilter. And in America, the politicians lack courage and they haven't been able to come around to having the conversation of we need to invest in preventive and early detection and not just in expensive treatment. And they're all complicit. The American Academy of Pediatrics recommendations on obesity that we give a $1,600 a month shot to everybody that's obese, which is up to 40% of kids. And,
Yeah.
they might say only BMI above this, but honestly, I mean, this is very politically incorrect. But honestly, you're going to deny the 14-year-old Black kid who is BMI of 85% and wants to lose weight the medication? No, you're not.
Yeah.
You're going to say they're going to think I'm racist, that I'm discriminating against her, that it's not equitable, that's this, that's that. I'm going to write the prescription. And if Medicaid pays for it, Medicaid pays for it. And if they don't, the family's still going to like me. And is that the solution for obesity? I mean, that's $20,000 per kid per year for the rest of their lives with one single study that had 200 patients and 1 year follow-up. And everybody knows from the adult medicine, once they stop taking the medicine, they regain the weight.
Yeah.
So again, could we think about ways of helping children not be obese? Yes. Should it cost 20 grand per kid? No, but it's very easy. Here's a drug. Everybody's happy. The doctor prescribes it. The family's happy. Where's the money come from?
Yeah. Yeah. I can see where you stand on that issue.
I think if the patient comes in, we've had a lot of success with my associate, Dr. Riley. He has a full obesity clinic in a private practice without a million tests, without a million specialists and consultants. And he's had positive outcomes.
Right.
He's done the right thing. So we use the obesity program as leverage to negotiate better insurance rates, contracts.
Mhm.
So the quality, fixing the money.
Yeah. What if you go even earlier, though? One of the things that I think is underappreciated about pediatrics, a lot of what I did in clinic was teaching families how to feed their babies, right?
Yeah.
How do you feed yourselves? How do you put family dinner on the table economically and efficiently? And all of that requires behavior change on the part of the parent. So when I think about obesity, so we could think about it in terms of obesity treatment, right? Which a large percentage of kids need that. But what about the ability to do that upstream more, to take the time to actually do the type of counseling, behavioral support, nutritional support that families need early on? Have you seen any practices that are able to do that
Yes.
and be reimbursed for it?
No. Yes. So Jim at RBK Pediatrics has a wonderful video on not doing sugary drinks. And, his point is always when that parent comes in with a 2-week-old and says, does the baby need extra water or maybe some juice at some time? His answer is never. Breastfeeding and formula is all your baby needs. When he graduates a little more, he can have water. He doesn't need any sugary drinks the rest of his life. Right?
Yeah.
That's where it starts.
Education. He's starting with education.
With education, right? And he does it in the exam room and he does it, through videos. Does he get paid for that? No. Zippo. But like George says, because they're not owned by a huge conglomerate, they're concerned, they're part of that community. They've been there for over 50 years and they're concerned with the quality of care they give their community. They are part of that community. Once you detach yourself from the community, you're just part of this huge, that's why the federal government doesn't work very well. They're all sitting in nice restaurants in DC, 20 minutes from my house, enjoying life. And they have no idea what on God's earth is going on in Alabama or Louisiana or, some of the neighborhoods in LA or some of the neighbors in Chicago. They never get there. They're too busy living a good life. And that's what happens when a doctor goes to a huge health system. He's just now following orders from someone who's concerned about the money, the metrics that, how many visits you're seeing, how much money we're making. Is that the department failing? Is the department breaking even? And that's all they're concerned about, and then they get in their car and they go to a nice neighborhood and that's it. That's all they care about.
So can we back it up a few steps and talk about some of the practice models that you guys have highlighted and which ones you think are working best in the current system? Which ones are maybe even reimagining how it could be? I wonder if you can highlight some, or maybe let's just start by in terms of the general practice styles, or the business of pediatrics, or the business models, can you categorize them?
Well, I think most pediatricians want to do the right thing, right? And I think the Bright Futures and AAP, they have a nice academic, you should do this, this, and this, and they brainwash or they embed all these things into physicians' brains that they have to do all these things at a visit. It takes a long time. Then they come to an office. And then, oh my God, I got to see 20 patients. How am I going to see 20 patients? So, because they don't know how to get out of their own way, I think, because they have, 26 different things that they got to talk about. The problem is you cannot spend an hour with every single patient. And truthfully, I don't think I want to spend an hour with Dr. Bravo in a room talking about eating and stuff. It's boring.
And the patients don't want you
They
to
don't want
spend
it.
an hour.
So
You
you have
know?
to find the efficiencies, work plans, something that works. What we did, this is Dr. Bravo's brainchild, is why don't you make anticipatory guidance, little video snippets, and things about vaccines, what vaccines are to be given at every single visit. So we send a little video, a little text message to every patient. The doctors of RBK would like you to watch this video. And in the video, we have two physicians, myself and Dr. Scott, younger generation, where we talk about at every visit, you should do this, you should do that, you should save and so forth. Talk about different viral illnesses. He'll ask me, so in your experience, Dr. Owen, did you ever see measles? Did you ever see chickenpox? And of course, I'll say, yes, I did. We treated it. We had this. Telling them stories. 3-4 minute videos, and everybody watches it. You did all your anticipatory guidance. You did your job. And in the room, you can talk about whatever you think is appropriate. The kid's drinking juice or something, say you don't drink juice. Or she leaves them on the table, unattended, tell them, don't fall off the table. Common sense stuff. So a relationship dialogue, not a didactic, I'm talking down at you dialogue that takes 2 hours to do because it'll never get done. And the physician will be happier. She'll be more efficient for the practice. They'll get out of the room faster and everybody will be okay. But it's all efficiency. And most physicians are inefficient.
I think that is.
Regulations.
If it's a joke,
Yeah.
EHR was foisted upon us when it was not ready for prime time. It's still not ready, although there are workarounds which are making it more productive. This MOC is a joke. And the general idea that the lawyers who write the legislation put on the public is physicians cannot be trusted.
Mm.
They cannot have, we have to have stark laws, self-referral laws. They can't unionize. They can't talk to each other because they'll collude on the pricing. We need to police them. They can't receive a pencil or pen from Pfizer because they might give you a vaccine in exchange for that pencil. I mean, it's basically offensive, but yet they go out, and I'm not complaining about Justice Thomas, I think it is, but he can go on a $500,000 vacation with his friend who paid for it. And that's okay because the lawyers can be trusted.
Yeah.
But I can't be trusted to take a pen from a pharmaceutical company because I might prescribe something for a kid, something that costs $100? Are you out of your mind? And, all this regulation handcuffs you, like you're saying. Like, why do I need to bring somebody in the office to see how they're doing? Because otherwise I spend the whole day on the phone and not make a dime. But your lawyer, your accountant, any other professional in America can pick up the phone and say, hey, Herb, I need you to bring this and that to finish your tax return. Could you send it to me through DocuSign? And you do. And, my lawyers send me emails and there isn't anything more important than not the lawyer client relationship. But they're not bound by it has to be encrypted and you could get fined this much if it lands in the wrong desk. Oh, so what? So when you make a phone call through a regular phone, if anybody has a regular phone, that's not encrypted. Anybody could tap that. When I send a letter to someone, anybody could open it and read it. That's not encrypted. So
Or fax machine for that matter.
the fax machine is not encrypted, right?
The then how do you explain the disruption that's happening now where because we haven't been able to service patients, these digital health companies are coming in and doing it for us?
Because they can.
because they can. And second of all, because you are beaten like a dog till you have no hope as a physician in America. And so every time I talk to physicians about you need to do A, you need to do B, or you need to do C, they go, oh, but that could be seen as colluding. Oh,
Yeah.
but it could be a HIPAA violation. Oh, but the AAP said, oh, but my medical board might object to that. So you can never do anything differently. And so we're seeing patients minus the HR, which is horrible, and the electronic scheduling appointments like we did back in the 1950s. One at a time in the exam room with a stethoscope, and we can't change.
But so you're describing a population of pediatricians who are disempowered, it sounds like.
They've been
Yeah.
disempowered 10 years ago.
Right. So
20
the
years old.
question is, to what extent is that maybe the culture or the type of character that goes into pediatrics, sort of conservative, right? We take very seriously any tests that we do on children for fear that it will cause a problem. And to what extent is, as you said, external factors? That's what I wonder about.
Well, that's why we created the podcast, because I think is we stop talking to each other, we stop listening to each other, we stop acting like a community, and we allow the health plans, the legislators, and the hospital administrators to decide for us what they're going to do. And we just do what we're told. And it's miserable because I'm not saying they don't mean well. They obviously mean well. I think there's very few legislators that are totally kooky that, mean to harm any segment of the population. But they have no idea of what they're doing with that pen.
Yeah.
Zero. And I mean, even Obama thought EHR was a great idea, which if you think about it, yeah, of course it's a great idea. I can go to any ATM and withdraw cash from my bank account, which is not even in that bank that I'm withdrawing the money, and I can be in second. So why shouldn't healthcare run the same way? But it doesn't, it's a lot more complicated than withdrawing money from your ATM. So until these regulations are adapted to what the customer wants and the time that we are in, it's not going to change. And it seems like the academic centers love to add bullet points to everything that a physician does. And the honest truth is, most parents, when you walk in, and this is what I do, I ask, what questions do you have for me?
Yeah.
What is it that brought you here today? Because that's really all they want to talk about. And then once they're done talking about their concerns, then you can give them an instruction sheet or a video and say, this is what we expect of your 2-month-old. And these are things that really worry me if you see in your 2-month-old. And I need you to call me. I don't need to go through the whole Bright Futures and check them off, because they don't have the time and they don't want to hear it.
Yeah.
But we don't have a relationship. They very much, and I hear this complaint from well-to-do educated parents and from poor parents. It's a waste of my time.
Yeah. And even the people who wrote the Bright Future stuff, they themselves say it's impossible to do with a visit.
Yeah. I have a talk that I give to digital health companies that outlines what we need to do in a visit, and be very clear that it's an impossible task.
It's about just clicking those things.
Yeah.
So, the EHRs have a listing of the different things, and you as a physician should go off on different tangents and talk about different things that you feel are appropriate for this particular visit.
Yeah.
Yeah.
I just want to reflect something to you guys, just because I'm having the same feeling that I had a little bit when I was in practice. I think I always felt a little bit like the maverick in the group, and and sort of always trying to problem solve, couldn't really understand the barriers and tried to navigate around them. And then as I have spend more time with digital health companies and health innovations that are targeted towards children and families, it's apparent to me that that's the polar opposite, right? And so then the conservative side of me comes out and says, well, what about this? What about the pediatric medical home? What about follow-up? All the sort of things that we say. The piece that's troubling me is that there probably needs to be some marriage of the two. And so I'm interested to understand how you two think about that.